This is the hsCRP Insights for Healthcare Professionals Vodcast series, brought to you by the American Heart Association. Lifelong learning. Listen, learn, and increase your knowledge on hsCRP and systemic inflammation.
Welcome to the American Heart Association's hsCRP Insights for Healthcare Professionals Vodcast series. In today's episode, we'll be hosting a panel discussion on screening. I'm Dr. Amir Rezvan, and we're joined today by our distinguished colleagues, Drs. Paul Ritker, Michael Garshik, Caitlin Voigt, and Brendan Everett. Thank you, everyone, and welcome. We would like to start with a very basic question as to what is hsCRP and what are its normal levels. Paul, would you care to start with that?
Sure. Thank you, Amir, for hosting this event today. It's really great to be talking about hsCRP broadly. We're in a real revolution right now going on in the diagnosis, screening, and treatment of atherosclerotic disease, where we now recognize that inflammation and hyperlipidemia both conspire to drive the initiation and progression of our patients' events. And we're in a remarkable therapeutic period of time where we have treatments that can both lower cholesterol and lower inflammation for our patients. So this is going to be a fun, broad discussion. C-reactive protein is a downstream biomarker of a silent inflammatory process that really reflects upstream activation of certain inflammatory cytokines we'll hear about later. But it's our clinical tool. It's the easiest way we have to clinically measure this low-grade silent inflammation that we now know is very important for predicting short-term and long-term risk, both among statin-naive and patients taking statin therapy. Broadly, levels of hsCRP in milligrams per liter, less than 1 is considered sort of lower risk, 1 to 3, intermediate to moderate risk, greater than 3 milligrams per liter, higher risk. A lot of our clinical trials use a value of greater than 2 milligrams per liter as we try to target our anti-inflammatory therapies towards people with a pro-inflammatory response. But some of you will notice as you're using hsCRP, you might get a value that's quite high, 8 milligrams per liter, 10, 20. What our recommendations have been is when they're quite high, you might want to repeat it. And don't take the average, take the lower value. The lower value is probably more reflective of the long-term inflammatory status of our patient. Because remember, CRP is an acute phase reactant, so we don't want to measure this while a patient's acutely ill. We want to measure it just like we measure cholesterol in a stable outpatient setting. This is really about preventive cardiology. One of the remarkable things is that in our large-scale Jupiter trial, where we measured hsCRP every year for 5 years, the variability was actually not much worse than things we're very comfortable with, basically comfortable with blood pressure measurements and LDL measurements. But if you get a very high value, just toss it out and repeat it before making a long-term commitment.
So I'm going to make a follow-up question on that because you brought up an important issue, such as measuring blood pressure, for example. We know that if we measure blood pressure once and it's elevated, we recommend to measure it at least a second time. The same way as the hsCRP level could be high in an acute phase scenario with levels above 12, one could imagine that you could catch it on the downfall period. So would it be reasonable to say if you have a hsCRP level that is not low, but in the moderate or higher range, would it be reasonable to recheck it at least once and take the lower measurement?
Yes, Amir, I'm going to answer that with 2 very different pieces of the puzzle. The first is at a pragmatic level for one patient sitting in my clinic. Absolutely. We want to if we're going to make a lifelong treatment decision, I want to have a pretty good handle on where their inflammation's at. By the way, our guidelines for years have suggested that we measure LDL cholesterol twice before we actually intervene and blood pressure twice before we intervene. All I'm saying here is take the lower value, not the average. That's probably the only difference of this. But let me flip the entire script on you. We just published a very large paper in the New England Journal a couple of weeks ago, 28,000 initially healthy American women followed for 30 years. And a random single hsCRP proved to be, if anything, a stronger long-term predictor of risk than either LDL cholesterol or LP(a), both of which, of course, are very important in a preventive cardiology arena. So one of the important lessons there is that despite the theoretical and real increased variability that hsCRP has, its biologic importance is even greater because all that's a bias towards the null. So anyway, for an individual patient, measure it twice. On a population basis, go ahead and realize the impact of inflammation is very, very large. And I guess the bottom line for this segment, Amir, is, physicians won't treat what they don't measure. I can't imagine giving a lipid-lowering drug without knowing the LDL. I can't imagine treating blood pressure without knowing the blood pressure. If we're going to move into this new era of thinking about inflammation as a target for therapy, we're going to have to measure the biomarker.
Absolutely. Thank you. Michael, do you mind kind of telling us a little bit about other inflammatory conditions that would raise CRP and how that ties into the heart disease risk?
Right. I guess, a follow-up to Paul's comments are that after you measure it, you have to explain it to the patient. And oftentimes they say, well, doc, what is this? Where is it coming from? Why is it elevated? And so, as someone who focuses a lot on the intersection between cardiology and rheumatology, many times I have a slightly different response than a lot of the other providers who are seeing patients without autoimmune conditions. But fundamentally, as Paul said, CRP is an acute phase reactant, how we initially discovered in the 1930s, and it's made in the liver. And a lot of the central drivers we find of that are key cytokines that are also pathogenic in atherosclerosis, such as that IL-1 to IL-6 CRP pathway. So IL-6 is really a central driver of CRP. Other central drivers can be LPS or lipopolysaccharide. TNF-alpha can do it as well. And it just so happens that a lot of the conditions that I tend to study, such as rheumatoid arthritis or psoriasis or psoriatic arthritis, have a very high IL-6 or TNF signature. So autoimmune disease can be a central driver or a central promoter of CRP elevation produced by the liver. But then, of course, we have other etiologies of CRP as well. So infection, clearly. But then there are other ones such as obesity, diabetes, metabolic syndrome, which again, adipocytes have a lot of TNF. They produce TNF, so that can again be a central driver of CRP elevation made from the liver. So those are some of the ones that I talk about, in addition to potentially dietary reasons as well.
Amir, I might add that, Michael takes care of patients who have visibly obvious inflammatory disorders. So he's a fabulous doctor for folks who have, severe psoriasis, ankylosing spondylitis, all the sort of interesting itises that we deal with. But for cardiovascular disease prevention, we're talking here about silent, low-grade inflammation. I can't look across an audience in an auditorium and guess whose hsCRP is going to be high any better than I can guess if their LDL or their blood pressure is high. So for most of our patients, it's actually this silent, low-grade inflammatory response. Michael takes care of the really sick people who have these chronic debilitating disorders. But what's been fascinating, and Michael's own research has shown this, his patients actually all have elevated cardiovascular risk. So I think one of the things we've learned biologically is that inflammation from any cause is experienced, if you like, by the vascular endothelium as a threat to the organism. And so all the patients Michael see have accelerated atherosclerosis almost across the board.
Right. And just to the flip side, I don't go necessarily searching for an autoimmune disease when I have a patient with a high CRP. I always take a history, and we do that all the time, right? Make sure you're not infected, make sure you don't have a cold, make sure you didn't get a vaccine, how are your joints, do you have any swelling, any weird skin rashes? But I don't go shotgunning a whole bunch of autoimmune antibodies or when I see a CRP elevation.
So I'm hearing a common theme here, and that is if hsCRP is elevated for any reason chronically, that will be contributing to the higher risk cardiovascular risk of patients, and therefore may be addressed with plans that we will discuss in a bit. But if it's up as an acute reaction to an infection or anything else that's acutely elevating it, that puts us in a different boat. Is that fair to say?
Yeah, I think again, if it's very, very high, that's one of those times when you want to repeat it. And again, call the patient and say, hey, what's going on in your life? And that's happened to me quite a bit, actually, where in my other hat, I do a lot of pericarditis work. And sometimes when I'm checking a CRP, it's very high. and I'm surprised. I call the patient, like, oh, I just had a cold. I'm like, oh, okay, I wish you had told me, so we wouldn't have ordered the blood work. But let's repeat it in a few weeks when you're through with the cold, because the half-life is not so great for the CRP. So you can wait till their symptoms are resolved, and then you can recheck.
Yeah, I think the clinical thing, Amir, is just go ahead and measure this in a stable outpatient setting, usual visits. But when it's high, it's usually very high, 20, 25, 40, you know it's out of bounds.
Right.
We're looking here for that lower level.
So we'll switch gears a little bit, and I would like to ask, how does high sensitivity CRP compare to other biomarkers that have been used to predict cardiovascular diseases? I'm going to first let Brendan chime in, and everyone else can then give their thoughts.
Yeah, thanks, Amir. So I think what we've learned, or increasingly learning, is that cardiovascular disease and atherosclerosis is driven by a number of different processes, right? And to the extent that we're able to measure those pathobiological processes, we can target our therapies better to do a better job of preventing heart attack and stroke. And so CRP has been directly compared to a number of common biomarkers. Total to HDL cholesterol is one, LDL cholesterol, blood pressure we've talked about already, and Lp(a) is another one that we've mentioned. It's essentially equivalent. I think that there's a fair amount of variation that happens in these biomarkers, which we've discussed already. And so when you look in large populations, that variation tends to sort of be evened out as you look at statistical associations between biomarker concentration and the outcome. As we've also discussed, of course, the smaller variations that you can see in an individual patient may be just noise from their day-to-day lives. I think CRP compares favorably to many of the biomarkers that I've just mentioned. There are other ones that I think are probably they're not new, but we may call them novel because we don't use them as routine predictors like NT-proBNP or BNP, some of the more sensitive cardiac troponin assays. And I think CRP has been demonstrated to associate with outcomes in a broader array of cohorts than those two. The other one that I think is, I don't know if you want to call it a biomarker or a disease marker, is coronary artery calcium. Probably that's the best marker we have of future cardiovascular risk. And so I think that that particular measure or biomarker, if you want to call it that, is probably superior to the ones that we've just mentioned. I think the other key part of this, of course, is as I mentioned earlier, does the biomarker then link to some kind of therapy or intervention that you can take as a clinician to help your patients do better? And for many of those, blood pressure, LDL cholesterol, or even total to HDL cholesterol, we have an avenue to pursue. And I think increasingly with CRP, that's the case as well. And I suspect that we'll get to that a little bit later in the conversation. But that's important to consider when you think about measuring biomarkers. What's going to be your response? How do you, as Michael said, how do you explain it to the patient? What does it mean? And also, what is your clinical opportunity to respond to that and alter your course of care because of the test value?
Amir, I want to echo something Brendan said. It's really important to understand. If your sole goal is to predict who in an apparently healthy population is going to be at high risk, there's no doubt that coronary calcium scan wins. I mean, it's because you're seeing the disease. The problem with coronary calcium, it doesn't tell you what to do. So I think we have to have a marriage in preventive cardiology between an imaging technique that says, aha, this patient has risk, and then measuring the LDL, the CRP, the Lp(a) to figure out which biology we want to actually target for the individual patient, because it's no longer a one-size-fits-all world. And I think that's what Brendan's really trying to get at in the broader picture of this. So we have to kind of bring together the imaging and the biology pieces. All these things are now inexpensive. And I think that if we can get to that point, we can actually target our therapies much better. For example, it doesn't matter if one's better than another. The question is, what's my individual patient have? I mean, if someone's got a very high Lp(a), I'm worried about that patient for that reason. If they have FH, I'm worried about that patient for that reason. So I think we just ought to make universal screening for these things done and move forward.
Well, I think you're talking about central drivers of disease, whether it's the LDL, the Lp(a), the hypertension, the obesity, the age, the underlying systemic inflammation. It's all about a piece of a puzzle in targeting each one of those. That's a central driver.
You brought an interesting point, and that is screening for hsCRP. And so I'd like to kind of open this up to everyone and see, what could be the potential benefits and the drawbacks of doing a screening for hsCRP, given that, it is probably a early marker of future cardiovascular disease. What is the age that you would recommend checking hsCRP if we look at it as a screening potential? Caitlin, do you have any thoughts on that?
Well, I think first and foremost, we need to marry the idea of implementing this as providers and in office settings and measuring CRP, but also coupling that with education to our patients, right? So we know blood pressure, cholesterol, those have been a part of the conversation for a long time. And when we're talking about our patients in the general public, they're aware that these are associated with cardiovascular issues down the line. And so as we're incorporating this into practice and in screening, I think it's really important that we also bring in that education piece. What is hsCRP? What does that mean for me? And what can I do to prevent it from being an issue? Or if it's already an issue, what can I do to help mitigate any further issues from arising?
Paul, you want to expand on that a little bit?
Yeah, so I completely agree with Caitlin. I think that education is the basis of where we have to start. And again, as Caitlin points out, our patients have been told for 30 years to worry about their cholesterol, worry about their blood pressure. It's very important they continue to do that. And whatever works to get them individuals to diet, exercise, stop smoking, go to the gym, it's all good. All those things, by the way, are anti-inflammatory, and they all will lead to lower CRP levels. And we're going to come back to the obesity question, I think, a little bit later. So that's all great. But let's kind of move now into the pharmaceutical side of this. So if you got an elevated CRP in primary prevention, beyond diet, exercise, smoking cessation, we ran a clinical trial published in 2008, quite a long time ago, called Jupiter, that showed that being on a statin was highly effective at lowering your long-term risk of a heart attack or stroke, even if your LDL cholesterols were already low, and the only real risk factor you had was an elevated hsCRP. The enrollment criterion there was a CRP greater than 2 milligrams per liter. We had a 44% reduction in heart attack, strokes, and cardiovascular death, and a 20% reduction in all-cause mortality among patients who at the time would never have gotten a statin, because the average LDL in primary prevention in that trial was only about 100. So I think, broadly speaking, the statins as a class of drugs would be probably your next step. Michael has asked the issue here about secondary prevention. We showed a year ago or so that in secondary prevention among people taking a statin, the CRP, again, is probably more predictive of the long-term outcomes than is LDL. But again, all of us are very aggressive LDL-lowering docs. The question is, are we going to add some anti-inflammatory therapies on top of that?
Right. I think we talked about, the power of the calcium score. And I think that the low-hanging fruit in my mind is the secondary prevention, because in the primary prevention, I think it's all complementary, whether it's the CRP, the lipids, the hypertension, the calcium score. But in secondary prevention, especially these patients that are having recurrent events, you've optimized the lipids, you optimize the blood pressure, and you still feel they're very, very high risk. I mean, this is really, I think, the sweet spot of this, at least the low-hanging fruit, because it's really not being implemented, the checking of it and the targeting of it with anti-inflammatories.
Thank you. Brendan, would you mind telling us a little bit about how lifestyle modifications can change hsCRP, and how does lifestyle in general correlate with hsCRP levels?
It correlates as we all might expect, I think, which is to say that if we are, the thinner we are, the more we exercise, the lower our CRP, if we're non-smokers. There are good data actually to suggest that if you are overweight or obese and you lose weight, that you're able to reduce the CRP, that CRP comes down per kilogram of body mass lost. That's true whether the approach was, and these data are from before the advent of GLP-1 receptor agonists, but whether you reduce your weight through dieting or through surgery. I think more recently, we have this brand new world where we have effective medications that treat obesity, particularly the GLP-1 receptor agonists. And data from those studies have also shown that as you lose weight, you also reduce your evidence of ongoing background inflammation, with hsCRP being the primary marker. The same is true, I think, for regular exercise and for smoking cessation, although at least the data that I came across suggests that the response of the inflammatory system to smoking cessation is slower than we might anticipate or might expect, on the order of years instead of sort of immediate. So if we didn't need another reason to not start smoking, perhaps that's one there. I can see that Paul is shaking his head a little bit, so maybe he has something to add to what I've said so far.
No, not at all. I completely agree with what you're saying. I was just reminding ourselves that, smokers don't get the benefit of having stopped smoking for cancer for a long time, but the cardiovascular benefit usually accrues within a year or two. So I think the timing of this is about right.
Yeah, that's consistent with the data that I saw.
So, Caitlin, what do you think are the barriers in universal hsCRP screening? And, how can healthcare providers ensure an equitable access to hsCRP screening?
I think there's a few things to consider here. So when we're talking about screening, we want universal screening. We have to make sure that everybody truly has that access to that screening. So we don't want this to be a common thing only done in certain settings, large academic medical facilities and associated offices. We want all of our local community providers to be implementing this type of screening as well, and education to their patients, clearly. And so we need to consider things like socioeconomic background of our patients and cost to patients when we're implementing universal screenings. We also have to consider, location, and can they access places who are implementing universal screening. And again, that goes to the point of we need everybody to be doing this and not just certain facilities. And then lastly, just again with the education and making sure not only our providers and our healthcare staff are aware and knowledgeable about this topic, but making our patients aware of the risk that inflammation carries to their cardiovascular health, along with like I said, the traditional risk factors that they are more familiar with.
Amir, I might add one other issue that's an interesting one. I think the US guidelines need to sort of catch up with our European colleagues. The reality of this field is that even though the vast majority of research was done here in the United States, at the most recent ESC meeting, the new European guidelines came out for chronic atherosclerosis and secondary prevention, and they gave a 2A recommendation. That's a very high recommendation. That's a, should be seriously considered recommendation for universal hsCRP screening in secondary prevention. And then they have a bit of a paragraph about utility in primary prevention. I think that's where we're heading. I'm sure that's where the US guidelines are going to head. And that's always a very nice way to let the general physician community know that something new is actually out there that we need to deal with.
I really find anecdotally the biggest barriers is sometimes from the providers. I precept in Vella's clinic once a week, and every time I presented a patient with who's having residual cardiovascular events, everything else is optimized. Say, well, let's get a CRP, and we have therapies now that will work for them. And there's a bit of a smirk or a laugh, or, oh, really, I should do that. And so I think that just getting this education out and talking about that we now have FDA-approved treatments when patients do have underlying systemic inflammation, I think it's really valuable. And I can tell you in my own practice, more often than not, many times the patients have come with me a list, and they say, oh, I have my Lp(a) checked, my ApoB, and my CRP. And I say, actually, we did a few months ago or a year ago. So I think that the public sometimes may know about it more than our providers. At least it's from my own anecdotal experience.
So I think that brings up a good point, and that is, okay, so if the hsCRP level is high, apart from bringing down the cholesterol that, is going to be important, how does that guide the use of anti-inflammatory treatments?
So I think as Paul mentioned earlier, I still think about going back on those core metrics, making sure they're on a high intensity statin. And again, this kind of differs if you have primary versus secondary prevention. So perhaps we'll go more to this when we're talking about target anti-inflammatories, maybe going more towards a secondary prevention route. But again, we make sure the lipids are optimized. If it's secondary prevention, they're on good antiplatelet therapy, blood pressure control, diabetic control, obesity control with the GLP-1s. But then when we have these patients that are still very high risk, that's when we start going to some of our more targeted anti-inflammatories, one of which is FDA approved, which is colchicine. And again, it's targeting that IL-1 beta to IL-6 to CRP pathway. So it's a really exciting time when we get asked, well, what do we do with an elevated CRP in the secondary prevention world where we have targeted therapies? And then, of course, as you know, we may bring up a little later, we have a whole host of other clinical drugs being studied in clinical trials.
Thank you. Anyone else has any comments regarding therapies there?
Yeah, I guess I would say that it's good to be proactive here. It's nice to think about residual inflammatory risk as a potential cause for your patients having future events. It's less glamorous to do that when they're in the hospital having had another event. Better to do it prospectively, if you will, in the clinic and try and tackle it beforehand so that you're not doing it after the fact when they're in the hospital having just had a trip to the cath lab for another stent implantation.
Amir, I might add that the FDA took it upon themselves largely to approve low-dose colchicine. It's a lower dose than we typically give at 0.5 milligrams once a day. It turned out to be very safe. 2 big clinical trials showed 25 to 35% relative risk reductions on top of statin therapy. But you know, there's not going to be any pharmaceutical promotion of any of this. This is effectively, you know, it's not quite a generic drug, but it's pretty close. And so I think we just have to, as Caitlin talked about, this is about education. What's fascinating to me, and I have the honor of running some of these trials, we're now working on a whole series of second generation inflammation inhibiting therapies. Some of these target interleukin-6 directly, looking in different settings. Chronic kidney disease, where risk is very high. And I should point out, in colchicine has a few contraindications. Kidney disease is one of them. Don't want to give colchicine to people with renal dysfunction. Another trial is going on in the setting of HFpEF, which is a really interesting issue about whether the fibrosis of HFpEF can be ameliorated to have clinical benefit for the patient. That's a really interesting question. And a very recent clinical trial just launched in acute coronary ischemia, trying to figure out, well, if we dampen down the inflammation in the coronary care unit and then keep it low for the next year or two, will that benefit our patients? The bottom line for me is we're at an exciting hinge point in this whole process. We're going to continue to be very aggressive with lipid lowering, very aggressive with blood pressure and all the primary prevention issues. But I think the era for thinking about anti-inflammatory therapy as an adjunct is here.
Great, thank you. So I think I'm just going to run and ask a, takeaway question from each of our speakers today, maybe starting with Michael here. What is, if you'd like everyone to take 1 or 2 takeaway home points, what are the key takeaways that you would like from our viewers to have?
Right. I think it's something that I already talked about or touched on a little bit, which is the concept of when you see a patient who has atherosclerosis and you're surprised that their lipids are not higher or their blood pressure wasn't higher, or they don't really have a remarkable family history. I think that's, again, if we're talking about really low-hanging fruits, that's really the optimal population to be checking this in. I think it should be checked in many more patients, but if you're looking at those ways to start, this would be the patient population I would choose.
Thank you, Michael. Caitlin, give us a takeaway.
I really think we just need to be incorporating this into the conversation more. It's starting to trickle, but we need universal understanding of the role of inflammation and how this impacts the cardiovascular risk for our patients.
Good point. Brendan, what is your thoughts on?
Well, we know that this is an excellent marker of future cardiovascular risk, along with other things like lipids and blood pressure and Lp(a). And so I think it behooves us to measure that and know where our patients stand as we get to know them. And then hopefully over the course of a long-term relationship with that patient, can intervene in over the years to try and prevent or defer cardiovascular events.
Paul, one or two key takeaways.
Sure. So, Amir, I'm just excited that we're doing this podcast. I think this is exactly what we have to have. As Caitlin just pointed out, it's about education. Look, as someone who's lived in the vascular biology, inflammation biology world for the last 30 years, there's abundant data supporting everything we're talking about here today, but it's the translation to the clinic, which is this point we're at now. So I'll repeat what I said earlier, which is the fundamental issue here is that physicians won't treat what they don't measure. We've got to start measuring inflammation to figure out what's the biologic issue that my particular patient sitting next to me in clinic today might have that I can address. How can I lower his or her risk? How can I treat his or her secondary prevention in a way that maybe wasn't what I was taught in medical school? But most of what I do in daily practice, I wasn't taught in medical school. And I think that's really what this is all about. It's Caitlin's right. This is about education. It's about learning new things. And actually, it's great for our patients because we can actually lower their risk and they can live longer, healthier lives.
Thank you. Thank you so much. So, when I think of, the discussion that we had right now, there are a few things that stick out for me. One is education, as you all mentioned, for us and for our patients. So we need to learn and they need to learn what hsCRP is and how it can be used. We have to keep in mind that there are actionable points in the measuring of hsCRP, and we can use it to guide our future treatment. And of course, we're going to adjust this as more data comes out and as we learn more about how we can use this going forward. We need to have this really accessible to everyone so that, once we think of it, we're able to test it and provide this maybe as a screening measure for everyone. And that, keep in mind that there are, both roles in primary and secondary prevention for it, side by side, other things that we are using currently. But I think that kind of wraps up what we're discussing today. So, I think we all need to be tuned in, more research coming out, and really think of, how we can start implementing this in our guidelines, such as the Europeans have. In a way that's going to be useful for everyone. I want to thank everyone for being part of this podcast. I think we all learned a lot, and at least some thought-provoking issues came up to make us learn and be aware of new data that's coming out. And I want to thank you all and wish you all have a great day. Thank you.
Thank you.
Novo Nordisk is a proud sponsor of the American Heart Association's hsCRP and Systemic Inflammation Awareness and Education Initiative. The views and opinions in this activity are those of the speakers and reflect the synthesis of science. Content should not be considered as the official policy of the AHA. To get additional information, please visit learn.heart.org for more education. Thank you, and have a great day.